diagnosis and advances in management. So we've been joined by experienced professionals in this field. Each speaker will be given 35 minutes. So I just want everyone to be attentive. Let's have our notebooks. And those who are going to have questions, you can type in the chat box. Mm-hmm. So our first speaker is going to be Dr. Lyon Chipandwe. Just to say a little bit about him, he's a graduate of the University of South Wales, UK, with further qualifications in aesthetic medicine from FDP South Africa. He currently serves as the Chief Medical Officer from Maryburg Health Services, Ndola, and Chief Executive Officer of Zambia Health Services and Lyon Aesthetics in Ndola. Over to you, Doc.
Thank you very much, Madam Elizabeth. Good afternoon, everyone. I would like to recognize all the students and a few colleagues who have joined, including my co-presenter, Dr. Tom. I acknowledge your presence and just thank you that we could all make it to this presentation on melanoma. Without wasting much time, I'll get on to my presentation. This is a joint presentation between the two countries. And so some of the slides which have been shared between the two of us, I will skip the ones that I know my colleague is going to cover quite extensively. Am I audible to everybody?
Yes.
Yes, please.
Okay, great.
Yes.
All
Can
right,
they
so,
share the slides?
Yes. Sorry?
Erize, can you share the slides?
Are you, yeah, Elizabeth, are they projecting my slides? You said somebody will project my slides?
Yes.
We'll share the screen?
He hasn't shared yet.
He hasn't shared. No, we can't see the screen.
Okay, let me help to share the slide.
Yeah, please. Okay, so maybe as he's trying to project, we'll just proceed and go on. So the outline of our short discourse is going to entail definition of melanoma, epidemiology, risk factors, pathophysiology, classification, clinical presentation, and I have thrown in a case study that we are going to discuss. So when we come to the classification, I'll just whiz through it. My colleague is probably going to tackle the TNM classification in his slides. So we're still trying to open. So basically, we all know that melanoma is simply skin cancer that originates from melanocytes. I'm on slide number 3. Just give him a chance to open the slides. Yeah, so basically this is skin cancer that originates from melanocytes. Now, melanocytes are very interesting cells. If you look at the structure of the skin, I mean, you cannot discuss melanoma without understanding how the skin is organized. We know that we've got the epidermis, the dermis, and the hypodermis. Within the epidermis, we've got the different layers of the skin, the corneum, stratum corneum, lucidum granulosum, and spinosum. We know that the melanocytes really are found sort of just at the junction of the stratum spinosum and the stratum basale within the dermis itself. Slide number 3, please. So melanocytes are very interesting in that I look at them, I think of them as a selfless, immortal cell. And the reason that I say that is because we know that they produce melanin. However, in their production of melanin, they don't produce the melanin for themselves. They produce melanin in order to inject it into the keratinocytes. And this makes them very selfless, because you're basically giving your shield to somebody else whilst you yourself remain vulnerable. That's why we never see melanoma in keratinocytes. It is strictly a disease that originates from melanocytes, because they're giving all their melanin away. The second picture that you see there is that these are cells which have got longevity. So naturally, they take about decades to actually reach their full maturation and death. They can go up to 10 years, 15 years more. So the fact already have a long life anyway. Now, we cannot talk about epidemiology without recognizing the work that has been done in the United States. So we don't see my slides. I don't know, is it just me or?
We all can see
Elizabeth, we all can't see the slides.
Rizé, can you again like share the
Let
slides?
me try and. Let me also try and see what.
Okay, I'm going to share it. Wait a bit. I've lost the connection a little bit.
Oh, I see.
Okay.
Okay, Doc, here you go.
Okay, thank you. All right. So we're now on the epidemiology. This is slide number 4. If you go and go forward, please. Next slide. Right. So when you talk about epidemiology, it is important to recognize the work that is done by a committee in the United States that sort of predicts the Cancer Society. It predicts what kind of cancer we are going to have at the beginning of the year, and possibly the mortality that is going to happen with those cancers. And from the postulation for 2026, they actually thought that melanoma was going to be, other than, of course, the prostate, the breast cancer, the lung cancer, which are top on their list. And this is data that is from America, adapted from America, but it sort of gives us an idea of actually what is happening, because it doesn't differ much, especially in the white communities. So we know that melanoma is the number 5 cancer amongst the cancers that they thought would be the top 6 or 7 cancers, and it's number 5 in men. Next slide, please. Number 5 in men, number 6 in women. We also know that the incidence over the years has spiraled upwards from 1970. Different scholars think that this could be because in the 1970s, obviously, we didn't have any data collection, and probably that is why they recorded very, very low rates of melanoma compared to now. They did not have the diagnostics tools, but what we do know is since the 1970s, we've had an upward trend. We also know that this is the most dangerous form of skin cancer, and it increases with age. Some scholars will tell you it's above the age of 40, but more consensus is that it is worse in the group that is above the age of 50. We also know that the older you become, the more you have the chance also increases. So once you are 50 and older, you increase by 1.5 every year that comes in men, and 2.8% chance of you developing melanoma as you get older above the age of 50. Coming to the risk factors, the next slide, please. We know that the chances of melanoma happens because of excessive exposure to UVA and UVB rays of the sun. And there's a concept called cumulative sun damage. We'll talk about that later. Skin type, if you look at Fitzpatrick skin types ranging from 1 to 6, we know that those who are prone are usually from skin type 1 up to 3. Freckle density is also a risk factor. The more freckles that you have on your face, the higher the chance that you're going to get a melanoma. People who like to do tanning baths, especially when they go to countries like Thailand, they like to tan so that they look a little bit brown. These have a high chance of developing melanoma. We also know that mutations in the cells, in particular the BRAF/RAS KIT mutations, can cause or predispose you to getting melanoma. The number of moles that you get, so most literature will say, 50 and above puts you at risk. And this is where we find a lot of practitioners doing photo finding, mole mapping, in order to count the number of moles and study the characteristics. So at about 50 moles, 51 moles to 100, you are 3 times likely to develop melanoma. And once you get above 100, that chance raises by about 7 to 8 times. Risk factors continued. We also know that immune suppression is a predicting factor for melanoma. Conditions like HIV and AIDS that drop the immunity will predispose you to getting melanoma. We're on the next slide, Mr. Nyirong. We're on the next slide. Personal positive medical history will predispose you to getting melanoma. Pre-existing skin diseases like xeroderma pigmentosa, pigmentosum, dysplastic nevi, P10, these can actually put you at risk of developing melanoma. Now, when we look at the pathophysiology, just to try and simplify it, I know we're speaking to medical students. Mr. Ellis, there's a bit of background noise from your, or one of us has got their mic on. Yeah. So in pathophysiology, next slide. In terms of the pathophysiology, but in the chart you see that we have UV radiation that comes, and there are 4 mitigating pathways that happens there. We have melanocortin secretion, which causes alpha MSH to bind and activate melanocortin 1 receptor. And in a normal individual, we have production of UV, which causes a skin protective pigment, which is known as your melanin. However, when we have mutation of this, I think this is a slide before, just under pathophysiology, when we have a mutation, instead of forming eumelanin, we form pheomelanin, and this now leads to no sun protection. And these are the people who have got red hair, red hair, light-skinned. That can happen with the mutation. We also have seen that the growth factor secretion and promotion is sort of stimulated by UV radiation. And when that proliferation happens, in the presence of genetic susceptibility and in the presence of predisposition for mutations, you will find that there is damage to the DNA of the cell that causes gapping and insertion of protein or abnormal proteins, if you so wish. So once that happens, we have got oncogene activation of the BRAF and then RAS mutations. These then lead to carcinogens, and then hence you can get melanoma. We also have another pathway where you've got genetic susceptibility. This does not necessarily need to depend on UV radiation. It can just happen because of loss of the tumor suppressor genes. In particular, we talk about CDKN2A. This is one of the genes that is responsible for suppressing tumor cells. When you are born naturally depleted of this, you are at risk. So the next slide that you are seeing now is I decided to throw in a pathophysiology of what really happens when somebody has got HIV or anything that causes the immunity to go down. But in particular, this pathway is for HIV. So what happens when there's HIV infection? We have got the HIV infecting the T cells. When the T cells are infected, we know that they break or they lyse. And when they break, we get a lot of radical oxygen species and radical nitrogen species. And these play an important role in the inhibition of P53. P53 and activation of P21. Now, the P53 is very, very important in ensuring that it's more like a caretaker that ensures that you do not end up with mutations that lead to cancer, if you may simply put it that way. Now, when your P53 is deficient, you then are predisposed in developing cancers, and it may not just be melanoma alone, other cancers as well. The other pathway in immune suppression is that we also know that there's what we call insertional mutagenesis and epigenetic silencing. So what the HIV virus does is it causes P10 disruption. So it will integrate its own viral genome or DNA in the host chromosome and then causes a decoding or disruption in the sequence of the suppressor gene P10. And once again, you've got suppression of the P10, it means you are now vulnerable to any cancers. We also have a process known as hypermethylation, where HIV infection will trigger a wave of host gen hypermethylation. Now, when this happens, we get modification of the genome, and which locks down and silences vital key cell checkpoint receptors. So instead of things functioning in the normal way, where we say, okay, where are you going? Who are you? Why are you overgrowing? Why are you not doing what you're supposed to do? All those regulatory mechanisms are disturbed, and that predisposes you to melanoma. The next slide, please. In terms of the classification, Elise, next slide. Elise, are you there? Okay. Okay, in terms of the classification, there's various classifications that are used. Because you are medical students, I've decided to simplify it by dividing it into etiological, anatomical, pathological, and clinical. And we all know that etiological looks at the cause, and in this case, is it coming from genetic predisposition? Is it coming from mutation? Is it coming from environmental damage, coming from UV light? That is etiological. Anatomical may differentiate, and there's a thin line between anatomical and clinical, because it may look at the features in terms of the position of where the cancer is, and histologically where the cancer is and how it is in terms of breast wall thickness and all that stuff. Clinically, it will look at the definition of those cancers. Pathological, my colleague who's a pathologist will speak about that. But for the purpose of learning, the current classification which is used now is the AJCC, American Joint Committee Cancer TNM staging system, which is used in essence by many sects of medicine, whether surgery, be it gynae, be it dermatology. So I had put also here just what you are seeing now, the etiological classification. Formerly, we used to use what we call the high cumulative sun damage low cumulative sometimes, and non-cumulative sometimes classification. This classification is outdated, and the reason is in red there because it correlates very, very poorly with clinical behavior, and is very subjective. It ignores a lot of genetic factors, and therefore it has become obsolete. Now, on the clinical presentation, just to take note, the next slide is that when you talk about melanoma, you look at basically the subtypes. And in clinical practice, we see superficial spreading, which is by far the most common. Well, on the next slide, Elise, 70%, of most of the melanoma that we see is superficial spreading. We have nodular 5%, lentigo maligna, acrolentiginous, amelanotic, and dysplastic. These are the subtypes that we have. Next slide is going to sort of show you there a few pictures. What you have on the extreme left when you're looking at the screen, this is a superficial spreading melanoma. The one on the right is a nodular melanoma. Now, I've put two nodular melanoma because I wanted you to take note of the fact that it is not always true that melanoma is going to be black all the time. So you've got a nodular melanoma, which is dark at the bottom right, and a nodular melanoma, which looks a little bit reddish or orangish or pinkish, if you may. That is also melanoma, and this is one of the things that makes diagnosis sometimes a little bit difficult in clinical practice, because there's a lot of mimicry of these lesions. At the bottom left is another different type of superficial spreading. The acrolentiginous, you are seeing it at the bottom there, that is on the foot, and what you see on the top of that page, top right, that is lentigo maligna. We go to the next slide, please. Remember, I told you that the classification is divided into etiological, anatomical, and all that. When we talk about anatomical, there is radial and vertical growth. My colleague will cover this in his slide, so I'm not wasting time on that. And then we go to the next slide, which talks a little bit more on the American Joint Committee for Cancer. Next slide, please, Elise. And the T basically looks at Breslow thickness, how deep the tumor goes in millimeters, and whether or not the tumor is broken or not. The N classification will look at the lymph nodes. What is the lymph node involvement? What is the size of the lymph node? And M is metastasis. My colleague should cover this. The next slide sort of like summarizes what the American Joint Committee on Cancer does, because when you combine the T and M, you basically come with what we call a melanoma stage. So you combine the T, what you find in the T, what you find in the N, what you find in the M, and this combination is what gives us the melanoma stage. The next slide shows you just as a whiz. Next slide, please. Shows you what we are looking at in brief when we talk about the T classification. So in terms of T0, there's no evidence of primary tumor. TIS, the tumor is in situ. Then you come to T1, A and B. Now, there has been a bit of an upgrade or changes since 2018 to this. Formerly, we simply used to say less than 1 millimeter is T1, and A is whether it is ulcerated or you go to T2, T3, 4. It just looks at basically how thick it is between 1 and 2. But my colleague will cover this. I will not waste time. The next slide looks at the nodes. We are at 30 minutes. I've got 5 more minutes. The next slide looks at the nodes and metastasis. Sorry, 10 minutes. We started at 5 past. And that again, my colleague will go through. This is just how you look at the regional lymph nodes. Can they be assessed? They can't be assessed. Are there any lymph nodes is there any evidence of metastasis or in one regional lymph node?
And Doc, we lost you.
Next one, let's go to, yeah, so after this one, next slide, skip, then go to the one that's talking about the CT staging for melanoma. I just want to show you a picture.
Hey, Doc, we
Staging. So
lost
there's
you.
you've gone a bit too far. Come back. Sorry, come back. Yeah, there, that one. So that just shows you when we say stage 0, you can see the dark thing that you're seeing there. No, you are going to back. The dark thing that you are seeing there, yeah, then the next slide, there you stop. Right, so it basically has cut the skin into pieces. There's a brownish thing that you can see. That slide, correct. What you are seeing there is just telling you what the melanoma looks like. When we say stage 5 or advanced, it's showing you how deep it is and all that stuff. My colleague will cover that. You can go to the next slide, which talks about clinical features. I'll leave this for my colleague. I saw this in his slides. He will cover that. Now, allow me to just briefly talk on the challenges that we are facing, in particular, Southern Africa, if I may put it that way. So in Zambia alone, we know how difficult it is to have access to a dermatologist. I think probably maybe now we could have maybe 5 or 6 dermatologists in the whole of Zambia. So already you can see that that's a knowledge gap, and that's a problem because it means that not everybody is going to have access to those dermatologists. So already expertise is lacking, and it's not just on the aspect of dermatologists. We also do not have dermatopathologists like my colleague Tom. So diagnosis in terms of histopathology is usually quite difficult. I would like also to reiterate that there's a high rate of mimetics and ambiguity. So you find that there's usually an overlap between what looks normal and what is not normal. So what happens is that some of the melanomas sometimes can be featureless. They may not follow the ABCD criteria. And then this usually requires expertise to be able to see, if you're using a dermatoscope, to be able to see. Otherwise, then you fall into overdiagnosis. We also have limitation in terms of screening technology. Our friends across the globe in other countries have started using AI for diagnosis. Research has confirmed that, yes, in as much as it is helpful, it unfortunately only marginally is better than practitioners who have been trained in dermoscopy. So even the AI is still learning. It is not as accurate when it comes to diagnosis of melanoma. Then the other challenges I've already talked about is histopathological challenges. We don't have pathologists, specifically a dermatological pathologist. We do not have one. And we also have disagreements between experts when maybe Dr. Chipandwe is going to say, this is this. Then Dr. Tom will say, no, but I think it is like this. So you find out that research that was done showed that sometimes there is more than 50% of ambiguity and disagreement of complex lesions amongst histopathologists. We also note that another challenge in diagnosis is the fact that some of the melanoma is hidden. We are on number 3. The next slide. We're on the next slide. Some of the melanoma is hidden. For example, the mucosal melanoma, the one occurring in the eyes, it is really hidden. And by the time you're diagnosing, the disease would have really, really advanced. Mucosal melanoma in the mouth, it's also difficult. And by the way, it is possible to get melanoma in the intestines. Now, imagine by the time you get those symptoms of abdominal pain, chronic abdominal pain, diarrheas, and all those things, you are way advanced. So this makes it very difficult to diagnose. And then also, of course, geographical access, education, and poverty. We know those people in the rural areas will not be able to afford to travel to Lusaka, to travel to Ndola, to travel to Rwanda to go and see a dermatologist. It is a high cost burden that they cannot afford. And then also lack of public awareness that these expertise are currently available. Now, the next slide, I'll just, and I'm closing now. I would like to just share with you a case. This, by the way, is a real case that is actually was admitted at my hospital. We just discharged this case yesterday. And this is a gentleman, 45 years of age, came into the hospital, was seen multiple times with a little sore on the left side of his foot, lateral aspect, just at the phalangeal joint where the toe joins to the metacarpals. And this lesion was troubling him because it could not heal. So they cut it. And on the third time, they said, no, you know what? It's not making sense anymore. Let's send you to an expert because, you know, this is not healing. By the time they did the first cut and second cut, they did not do any biopsy. But just to give you a bit of context, this is a gentleman who had advanced HIV disease. If you remember in the pathophysiology, we spoke about how HIV predisposes to melanoma. He defaulted ART. When we did a biopsy, we found out that indeed it was a melanoma. We sent him to Cancer Disease Hospital, but he refused the treatment. He said he doesn't believe that he has got cancer, so he defaulted treatment again. So this is how he came to us. You can see the ulceration there where the excision was done. Now what you are seeing there next is actually his leg. That is the left leg. This started actually as a lymph node. I don't know if you can also see that dark spot next to this fungating mass that he has. There's a dark spot there, which is melanotic and quite suspicious as well. Now, the next picture shows you, if you go to the next slide, unfortunately, in the labs, he was anemic, hypokalemic, his ESR was high, his CRP was high, his CD4 count was 5. And of interest, colleagues, is that if you look at the X-ray, now I'll pause this. I know when you do radiology, this is actually a goal question, and this doesn't miss in the exam. What are those lesions you are seeing on the X-ray? This is an X-ray and is a typical textbook classic example of a cancer. Those are called cannon balls. You can see cannon ball appearance there in the chest X-ray with the patchy opacities within the lung there. But what of significance, I wanted you to take note that this gentleman had distant metastasis to the lung already. And again, you can see the fungating mass there. I end my presentation here and would like to hand over to my colleague. But as my colleague comes in, I've got a bonus question before you ask us your question. So this question is for the students and any listeners. Why is it that you would expect people who work out in the sun, are exposed to UV radiation? Therefore, we anticipate that the rate of cancer, melanoma in them should be higher than office workers. However, research has proved it to be the opposite, that office workers who do not work outside actually have a higher incidence and the higher chance of getting melanoma. Why is that? So think about it as my colleague is coming in. And the moderator, over back to you. Thank you.
All right. Thank you
very much for that insightful presentation. We really appreciate the details. So for those who have questions, kindly type in the chat box. We'll have our responses after the second presentation. So our second speaker is Dr. Thomas Habanabakize, a consultant anatomical pathologist at King Faisal Hospital, Rwanda, with strong expertise in cancer diagnostics and skin pathology. He is actively involved in impactful cancer research and global cancer advocacy through organizations including USCAP, BDIAP, and Rwanda Society of Pathology. Over to you, Doc.
All right. Thank you for this nice introduction. Can Erize share my slide if you have? Erize?
Yeah, you can send to me.
Do you have my slide, Erize?
No, I don't have.
Oh, can you give me authorization to share my slides, Light, if you can?
I think you can share. You can share. You have access.
For taking time. I thought Erize had my slides as confirmed. So, Erize, can you see your WhatsApp and then share the slides? Because I have difficulties of getting my slide shared. Entire.
You can share them on my WhatsApp. I have texted you.
Do you see my slides? Did
Yes,
you
we can.
do?
Yes, Doc, we
Oh,
can see them. We can
oh,
see them.
cool. Thank you. Successful. Um, Thank you, Doc, for having elucidated some of the principles of melanoma, especially how we talk like cutaneous melanoma, as we said. We didn't talk other like hidden melanoma, like in GI, gastrointestinal tract, anogenital, or in the eyes, like uveal melanoma or ocular melanoma. So for this purpose, we say that is invasive cutaneous melanoma. So I'm gonna just take you through the approach to the diagnosis as medical students. Um, so you start by history taking, and that is being backed up by what Dr. Ryan shared you in terms of the skills and knowledge. And the first question, how was the region? Like the patient present to you, or you encounter any patient like in the Lord, you see any suspicious lesion, you have to interrogate that lesion. And especially when he comes in the surroundings of your clinic or the hospital, you ask whether when was that first lesion noticed, or it has been like a long lasting over 2 years, 3 years, that is a suspicious lesion. And then you ask about the color. Those are pigmented lesion, most of those melanoma lesion. But you also interrogate about the size, shape, like any mass, the characteristics you learn from the semiology, you guys, and ask the patient about the personal history or family history, we know that like 10% of the melanoma now they are familial. Because of maybe those ones predisposed to many genetic alterations, and ask whether the patient has sort of excessive sun exposure or tanning bed issues. Like, especially, they told you that in Thailand, some of the countries where they still have these practices of tanning the skin. So you really want to interrogate about these crucial or essential history in your history taking. And ask also for severe burns during childhood or teenager years, because we also have like pediatric melanoma. Those, yeah, in terms of epidemiology, most of the melanoma cases, they are in above like 50s now by consensus. But remember, there is also pediatric melanoma, as we are going to see. So, and also those familial atypical moles, especially dysplastic ones, dysplastic nevus. Nevus, actually, from what they told you in terms of pathogenesis, it starts like a nevus, like aggregates of nevoid, nevomelanocytes. Like, it starts like at the epidermal, dermo-epidermal junction, like without true invasion on histopathology. And again, that is also reflecting those questions that you have to ask in history taking. Does one get me? Am I understandable?
Yes, Doc, we can hear you loud and clear.
Oh, cool. And then
Loud and clear.
immunosuppression, that was elucidated by Dr. Ryan. He told you what is really the incidence of these melanoma cases, especially in those immunosuppressed, either HIV/AIDS or those that are like on immunosuppressive drugs. You see, there is unchecked those T cells, and also those pretend as he has like well explained in terms of pathogenesis. And on top of these important history taking questions, you have to do the total body skin examination. Like, have the patient like bear as entire, the whole body total surface should be examined by for those clinically suspicious regions, so that you find those ones that you would likely to investigate more in terms of histopathology, as I'm taking you through. And so just this has been so used as an approach, as a clinical approach related to history taking, and it has been varied from some of only subtypes of melanoma, ACBD rule, superficial spreading melanoma, as for histopathological like classification, as Dr. Ryan told you, rentigo maligna melanoma, acro-lentiginous melanoma. And when it comes to asymmetry, it's like when you bisect, like when you have a clinical lesion. I'm gonna just show you more on those below pictures in next slides. There is sort of like the two parts that you bisect, they are not equal, they are uneven. When you try to see all the borders of the region, and then the variation in color, like more than 4 colors, red, blue, black, so it is variegated. And diameter, again, that is very crucial in terms of measurement. It should be more than 6 millimeter. Evolution, how is this? I mean, the region has been evolving in terms of size, shape, and color. Again, are they new, de novo region, sort of new region, on top of this, the actual region that you are seeing? And sort of illustrative, like pictures for the ABCD rule. Look at this first one. I don't know whether you see it, like first picture. You see that is sort of irregular lesion that is pigmented, more black, brown, sort of variation in colors. Okay, and that is the second lesion. And that is asymmetric. Like if you try to bisect it into two, again, that is very asymmetric. You don't have the two parts that are equal. That's how we try to see the irregularity of the borders. And again, you have variegation in colors. That's what I try to depict. And then if you try to measure with a ruler, that is even more or equal to 6 millimeters. Okay. So apply this rule, especially that is a rule that is applicable for those aged more than 40 years or 50 years, per the current consensus. And that's what I try to look at this asymmetry in picture A. You see this yellow vertical line. Like if you divide, you bisect it into two, there are asymmetrical parts of the region of this mole. Okay, and they can't really match if you try to reunite them. And again, I think I won't rust. Those are again the picture for you guys. You can look for your mastery of the ABC tool. And I've shared you a link, a YouTube link. You guys you are in the era of YouTube. You have to learn and utilize and master these skills. So you will learn how to do on top of this ACBD criteria. And for this suspicious region through these ABCD criteria, you have to do total body skin surface examination, physical examination. And again, that is sort of deviation from this ABD rule. It is only varied and applied for the nodular melanoma. That is histological subtype and clinical region. And good that he shared you the picture for this nodular melanoma, sort of melanotic and then pigmented melanotic. And that is sort of a raised region from the surrounding region. It is like a nodule if you have to characterize it. And then you have to measure, of course, its shape, size, okay? And then it is sort of a nodule that is glowing over the days to weeks. So you have to question about this. So other signs for if you want to push further to investigate more other signs of melanoma is agri-occurring sign. So that is agri-occurring sign will insinuate sort of let me that will be you see that will be sort of a pigmented lesion that is more devoid of any like skin. So like if you see the on this picture, I'm not sure whether it is really showing up well. And then you have Hutchison sign. That is, you see, it is sort of like a breathing under the nail. And then you have the whole line taking the whole nail. That is Hutchison sign. And the bower fly sign, it's sort of insinuating this blow fly sign. It's like it's a fly on your skin. That is a mole, and it is among other multiple tiny mole when you look at the back on this picture. And then you have to interrogate about other dysplastic syndrome, like so many atypical moles, more than 50, like 50 to 100. So you have to find where this one biopsy, and then was this patient diagnosed as a previous dysplastic nevus. So this one will be in that category of dysplastic nevus syndrome. And then BAP1 tumor predisposition, those one who have known at genetic alternation like BARP1, as we've seen, like normal cancer as melanoma is concerned, it's genetic. It's genetic a disease when it comes to like to show to exhibit or to demonstrate those BLAF mutation that are really altered. And we have to demonstrate this by different various laboratory methods. Ectoderma pigmentosum, these ones, they are very predisposed because of an defective gene like XPA and XPC. These ones, they are very predisposed to severe sun exposure. And these from the pathogenesis and pathophysiology, these ones, they are only predisposed to melanoma, also to other skin cancers like basal cell carcinoma, squamous cell carcinoma of the skin. These ones, which are the top, and the melanoma being on the third in the terms of the skin cancers. Recently, Parkinson's disease, this one have been associated. Those patients who had like Parkinson's disease, they were also found to have high risk of getting melanoma either on the course of the Parkinson's disease, or they had melanoma previously prior to the diagnosis of Parkinson's disease. That is what the current research insights are now demonstrating. So these ones also needs to be interrogated during a physical or a history taking. Okay, I think I've given you the truth. So at least for you guys finishing the medical school, you should master these skills. We want to make impacts. Melanoma is not only, as from the last case shared with you by Dr. Ryan, is not a skin of white people, even everyone. Okay. Again, for pediatric melanoma, the ABCD rule has been sort of changing in terms of, because it's not sensitive, to make it sensitive. They have also, because, they are not such pigmented because of maybe the cause of the disease. So they have opted for these ABCD and CAUP criteria. And that is a melanotic, they are mostly a non-pigmented region. And they look like a hemangioma, or sort of a breathing region. And see the color uniformity, you might not find those color variation as showed in those other region. And the novel, how are they coming? Any diameter? The diameter of more than 6 meters don't apply, because those schizoid melanoma in pediatric population, especially those under age of 20, that rule does not apply. Yeah, and then color might be only pink, no more than 5 colors. But what is the pattern is that that color is changing over time. And then acceleration, yeah, they need to be acceleration. I think you've got sort of an overview of what is staging. Acceleration becomes one of the most prognostic factors. Then some of them might look vascular lesion, like pyogenic granuloma lesion. So this rule is also helping in terms of screening, also diagnosing pediatric melanoma. Okay. And so that is one of the picture I've got from the up to date, as that is here even referenced. That was a schizoid type melanoma. And if you can see this region on picture C, this gloss picture, you would see that is more hyperpigmented region. But look at the picture B, you will see that is not pigmented, sort of a melanotic. Look at the picture A. It's not even a reason that you would interrogate more. But these ones, as they need to be screened with all those important questions that I have given you. Okay, and again, the emoscopy, that is most reserved in settings where we have a disposition of the dermatologist, who is very skilled in using the emoscopy. And those are typical features, especially these presence of those globules. Those are the features that are really alerting in terms of these the emoscopic findings. So hope that you are following up, and you will have many questions. So as an anatomical pathologist, a surgical pathologist actually, we know that the definitive diagnosis is more rendered on histopathology. And you can start by biopsy, especially that's what we do. And then that biopsy is followed by clinical staging. And after a wide surgical incision, we do like a definitive pathological diagnosis with all the elements. And histopathology as standalone modality diagnosis is not really a definitive, but it has to combine all the other parameters. As I said, what are the findings in the history taking, the physical examination. So and then the demoscopic findings. You see, it's not one standalone modality in the diagnosis of melanoma. Yeah, again, yeah, pathology is pulling out all those more than 6 mm dimension from the physical examination. But we know there is sort of microadenoma, those ones that with the diameter that is of less than 2 mm, especially in the pediatric population where the rule does not apply. And then asymmetry photograph that I will show you. And the Blessler-Dove has been one of the prognostic factor over the Clark levels. Yeah, it's sort of correlative, but the most important is the Blessler-Dove, and that is measured from the granular layer, that is the granular layer of the skin, and to the deepest of invasive cell. That is the role of the histopathologist or dermatopathologist, who has to measure this one because it is one of the prognostic factor in terms of managing the melanoma. We have epidermal findings. I think I will take you through some of my photomicrograph. And then demo findings, we have radio when the melanoma, especially for those one that are melanoma in situ, we still have like those atypical melanocytes at the dermal epidermal junction. They are not yet, we don't have the nest within the dermis. And then vertical growth, that is through this vertical growth, we have confluent nest, and then we have cytological features and stromal features. That is the whole work of diagnosing melanoma in histopathology. You have to appreciate all the features. So I didn't want like to bother you. I will discuss this one through the pictures to make it so simpler. And then we have histological classification, where possible, we do immunohistochemistry, especially for melanocytic markers, S1, HMB45. And as we told you, as melanoma, that is sort of a four-stepwise pathogenesis of melanoma or carcinogenesis. So BRAF mutation in most of the melanoma subtype is tested as immunohistochemistry or by FISH or molecular status. And then remember this gene was also like highlighted by Dr. Ryan. It is also like tested CDKN2, CDKN2A. That is P16 loss. It is also tested as immunohistochemistry in the lab, especially in those difficult cases. So like histomorphology alone, to make it like a final diagnosis of melanoma on top of physical history. So it has to be like so extensive to make sure that this melanoma, it is well staged, and then there is appropriate management. Okay. So sorry, I can't show you all those pictures, but they should really come up. Those are the melanoma, like where you could even use the melanocytic markers. I think I will show you. I couldn't like sort of make slideshow because every picture should come as a log to show you all the types of melanoma. But remember, there is superficial spreading melanoma in terms of histologic classification, rentigo malignant melanoma, and then acrolentigenous melanoma. And there is also those other subtypes that are not cutaneous melanoma. And so that is I think, yeah, that is tumor size. It's tumor size that is or the thickness, the breast depth. So not that the tumor size, it's about the breast depth. That is measured from the granular layer up to the invasive cell component, the last one in the dermis or in the subcutis, okay? And then the lymph node status, and there is what we call sentinel lymph nodes. This one there, when at plio biopsy, like you do a elliptical biopsy, you have also to do the lymphatic maps and see what is the drainage of these melanoma, or more cases of which I suspect it is a melanoma, an invasive melanoma. So that's one. Then there is distant, like regional lymph nodes, either in axilla, in guino, so or deep lymph nodes like mediastinum. So those ones need also to be especially those one will be harvested after a wide surgical excision of the melanoma, especially when they are stage 1 or stage 2. Otherwise, the other ones we need also like adjuvant therapy, such as immunomodulators or immune checkpoint inhibitors, targeting especially BLAF V600E and other like gene alteration that will be demonstrated by molecular studies. Metastasis, again, I think we use the other uh, tool that are well traced. Otherwise, we have also the tool in HICC, that is edition, that we use for the melanoma staging. So again, there is what they call tumor prognostic stage group. So we know that these ones will dictate after final stage, that will detect what is whether the initiated management to the melanoma is the right one, or the patient need like additional treatment plan. Okay. So that is as a synoptic or a template of histopathology that needs to be very clear and elucidative in terms of giving the way forward of melanoma. So invasive melanoma should be specified, which subtype, superficial spreading melanoma. The macroscopy, what you've seen, that is combined with the history and the actual specimen description, whether it is an incisional biopsy or a skin ellipse that was brought to you. I wouldn't take much of these. So that's for you, for your reference. And then you see that the glow face should be reported. That is insinuating an invasive cause of the melanoma. Blessed death, acceleration, the mitotic triggers, and so forth. So treatment modalities, you see the blessed death for wide surgical excision as modality. Blessed death, these melanoma subtypes can be like excised. But what if the sentinel lymph nodes is positive? That is predicts a recurrence of melanoma, even though you have done surgical excision. Those patients will need adjuvant or systemic therapy, especially when they are in stage 3. Okay, and some of them, there is so many, like now I think even in Rwanda we have some of these MEK inhibitors or KIT inhibitors, like pembrolizumab or imatinib. We have them available, and I think that is a more comprehensive melanoma management. Then we have the place of chemotherapy or radiotherapy, especially for those with metastatic melanoma with known primaries. So prognosis, we have those with young age, they tend to have, because we understand it's a multi-step carcinogenesis to have melanoma as such, with all the mutation authored. Some of them, they are in early stages in terms of when you've done like clinical stage or pathological stage, and they tend to have like good prognosis, that is favorable prognostic factors. Female, they have shown to have good prognosis compared to the male counterparts as gender. Then early stage, as said, especially stage 1 to stage 2. And then those ones who have like tumor infiltrative lymphocytes, so those are recruited like immune cell, hematopoietic cells. So these ones that recruit so many surrounding the atypical melanocytes or neoplastic melanocytes, these ones tend to have like cases have to have a good, a favorable or a good prognosis. So those ones with unfavorable prognosis, especially those elderly patients, those more than 90 years old, so or 60 years old above, male gender is a bad prognosis. Sorry. And high risk sites, those back, upper arm, head, when compared to other like sites, these ones have to have a bad prognosis melanoma. Of course, it's a constellation of other factors, like what is the stage, but when you compare to the same stage, they have seen that different sites have different like prognosis, even some with a decimal prognosis. So high breast depth, especially more than 1 millimeters, more than 2 centimeters, these ones tend to have a bad prognosis because the melanoma has grown deeper to the extent it is very distant even to other organs like the lungs, CNS, and so forth. So again, a selection, okay, it needs to be reported in histopathology reports. Then absence of infiltrative, so it's and then those ones that have already lymphovascular or perineural invasion, they tend even to get like local recurrence even upon wide surgical excision, if so, like appropriate modality initiated. So in terms of prevention, we've said that the main etiological factor is those ultraviolet B and A, especially B. So they advise people who are very like prone to melanoma to use to appropriate use the sunscreen. Those are the products that protect our skin from those UV rays, especially from 10 to 16 like o'clock. And then avoid induced tanning, especially where they still have craters. And a tanning skin is that skin that is minimally tanning, getting black, especially for those with fair skin. That is Fitzpatrick type 2. And then we have to educate to make awareness as you guys doing public health about UV exposure, and then use those protective measures, and then promote the skin cancer prevention policies, not only concerning melanoma, because we only know also that even SCC or basal cell carcinoma as top skin cancers, there is ultraviolet lights exposure that is one of the main etiological factors. And then we have to strengthen research. Yeah, in terms of epidemiology, we have so many data from those Western like world, but we don't have actually even some of the data in Africa. And then screening for those that are with all the risk factors, these ones at least they recommend to screen them to visit the dermatology clinic at least once annually. So, as illustrated by Dr. Ryan, you see the melanoma cancers in at least this year, by the end of this year, that is projected to lead to the cancer death, overall cancer death, at 1.4%. Okay? Though the survival rate, if detected early, especially that is the US data, that is 94.7%. Okay. So to bother you a little bit, look, I don't want to bother you a little bit with my skin like diagnostic approach. As histopathology being a definitive diagnosis, you see, you would see like you see from top down here as represented epidermis as our outer layer of the skin that is protecting on the basal layer where there is this junction from this dermis. If you remember from the normal skin histology, that is where sit on the basal layer sit the melanocytes. So as elucidated in pathophysiology, when these ones they are like their DNA is very defective, they are immotile and they are not like repaired by normal like our TP53 guardian genome is switched off. So this one try to grow from epidermis up down, and then they also glow into the dermis. I'm sorry if you were not mastering it. And look at this picture. Look at this nest. Look at this nest. Like that, maybe if you can refer to this whitish, more whitish, that is a nest of neoplastic melanocytes. Okay. That is what we call purgatory spread. And not only seeing it, you have to know that those are melanocytes that are glowing from. That's why what we see like a gloss picture, and the one like remember on the shared case like a node. So this one will make a mass, and that's what we see at the cellular level or the histology level. So many of them, the nest within the dermis, and then we can see some of them in the dermis. So that is nodular melanoma. You see a good chunk of those big nests in the dermis without a significant junctional like nest. Okay. And you would label this one, interrogate more, like ask whether there is no prior diagnosis, because when it is more dermal seated, that will be metastatic melanoma will be also will come in the list of the diagnosis that we make in histopathology. And again, we know that here you see this brown pigment is that is melanin. Actually, that is dispersed within these tumor cells, neoplastic melanocytes. So I think I won't bother you on this, but remember, melanoma, that is a constellation of both histopathology, clinical, physical examination, and where is ambiguous, like in those disagreement in 50%, we have to do also molecular. We know molecular as standalone is not is not giving the right, the right answer to a definitive diagnosis. You have to combine. It is a constellation of everything. Thank you so much. I think I've used the time according to me. Sorry if I surpassed it. Otherwise, thank you so much.
Thank you very much for the presentation. So at this moment, we're going to invite questions. Those with questions, kindly write in the chat box. Do we have people with questions?
Yes, yes, I have a question. I don't know
You
if I
can
can.
go ahead.
Okay. So, my question, I would like to ask a question to Dr. Thomas. My question, first of all, will talk about the scarcity of dermatologists and pathologists in Rwanda. You know, as Dr. Lyon has said that in Zambia, there is only 6 dermatologists. So, but for Rwanda, even I don't know the exact number of dermatologists or pathologists. I think they are still few. So, while the patient who have suspect of this skin melanoma, they first face the at the health center or district hospital where there is no dermatologist or or pathologist. So I would like to ask, why can't we capacitate the district doctors or those at the level of health center who used to face the patient at the first time to try to take sample and send the sample, not the patient, because some of the patients, some of the patients, they have economical constraint where they live for the patient, they don't have the capacity to live there or to stay there. I want to ask why, what if we capacitate the district doctor to take sample and transfer the sample instead of the patient? Thank you so much.
All right. It's really interesting. Maybe through the numbers of dermatopathologists. Yeah, we so far in Rwanda we have one. He's also a trained dermatopathologist. And on surgical anatomical pathologists, it's good. We have good number, and I think everyone is trained to know melanoma with all the consideration of all the parameters that I've discussed with you. It's okay that we missing a diagnosis maybe at the tertiary hospitals, either in Kanombe, King Faisal, Butalo, where we have like well-equipped pathology lab. I think it's not a problem, but we understand not like some of even skin condition, they are sort of neglected and people don't even consult area till the region becomes isolated, as we said, which is unfavorable prognosis. Yeah, there is a room to train. That's what I told you guys. You have a role in promoting skin cancer prevention policies and educating the public. And yeah, and that's why we are bringing this platform, you guys, as you are finishing up your medical school. And I think with your ABC that rule, at least you will refer the cases area in case you can't be like doing the send the specimen. Where possible, some of the surgeon can do the incisional biopsy and send the case, at least make a diagnosis while waiting a final definitive diagnosis. Yes, I think it's stepwise. It's not bringing everything at the health center, but at least some of these recognizing this region, especially suspicious region, it's a skills that you can train even to the nurse. Sure. Otherwise, there is a gap of doing not every anatomical pathology like skin, especially it is a tricky like subspecialty from even the clinical standpoint practice. And when it comes to even pathology, it's again becomes like you need to get trained the 4 years of surgical pathology and get a subspecialty of 1 year. Okay. Yeah, of course. Let's do that to you with you and with the skills that you acquired today and that will also apply for your next practice. Thank you.
All right. Thank you very much for the answer. Anyone else with a question before I read those in the chat box?
Thank you. I have a question. Hi.
Yes, go ahead.
Thank you so much. My name is Edson Zabahimana. Yeah, first year I'm a student in the Catholic University of Rwanda, Health Science and Department of Midwifery. Thank you for this topic today. For me, I'm very excited to be here. I have two questions. Allow me to ask you this a question.
Yes, you can go ahead.
Okay, the first three question I want you to tell us if this is skin melanoma, this is skin cancer, if it is genetically. Yeah, I think it is genetically disease, but I wanted to ask the many symptoms of this cancer uh, to the patient who have it. And another question I wanted to ask uh, as the founder of I want to ask which the purpose or which the objective we have to the public or the community for anyone who has this cancer but shouldn't go on the hospital. Says that it is like a bad spirit, it is like amarozi in Kinyarwanda. Yeah, I want you to tell me what is our initiative to help for that patient? Thank you so much.
Thank you for the question. I think Dr. Thomas, you can answer.
Oh, if Dr. Ryan is still there, I can just chip in and
Yeah, sure. Yeah,
yeah.
not a problem. Thanks. Yeah, thank you for the question. If I understood him well, the question was number one, is it can this condition be genetic? And at the
Yeah.
same time, to know
Huh?
about societies,
Many-
saying that this is probably witchcraft or something like that. Did I get that correctly? Was that the question? That it is Malozi. I don't speak in Yarki. I mean Kiganda, but I think Malozi is like somebody has bewitched you.
Yeah, sure,
Is
sure,
that the question?
sure, Ryan.
Okay, all right, yeah. So I'll tackle the first part. Probably you were not there when I started. One of the risk factors for melanoma is actually genetics, genetic predisposition. Other than the various conditions that we talked about, there are some people who are inherently born with certain diseases that predispose them to getting melanoma. We also have a genetic melanotic condition, which is known as FAM, familial acquired melanotic melanoma. It's called FAM. So this is a genetic disease. You can actually inherit this condition, and that predisposes you. Also, we know that people with MOS, if your mother, your grandfather, your relatives have got MOS, you'll find out that some family members will also inherently develop those MOS, and these can predispose you to melanoma. So yes, in short, melanoma has a very strong familial and genetic dilation. Now, as far as witchcraft is concerned, sorry, yeah, as far as witchcraft is concerned, that is not unique to Uganda and maybe to I think that's you could see that even though I don't speak Uganda, I was able to pick that, this probably means kulowewa. We have a lot of that, and it does relate to not just melanoma or cancer situations. It usually relates to what people do not understand. Even if you go biblically a long time ago, what people could not explain, they'll either say you were bewitched or you are demon possessed or you've angered someone who has sent you a bad spell. But we normally tend to take the position that we are scientists. At the same time, we do not neglect that alternative path of medicine, in terms of, for example, your religion could be looked at as a cult by somebody else, and is an atheist, for example. So what we do, like in my case, you respect what that client is saying. You don't have to agree with them, but then you tell them, in as much you might look at it that way, you educate and you take them through counseling. So to bring it much closer home, one of the patients who we had was quite a sad case. He had cancer of the right foot, and he believed that somebody had actually wished him. He left the hospital and went first for prayers. When they failed, then they went to a witch doctor. That failed. After everything else failed, he decided, okay, you know what? Let me go back since everything has failed. But by then, now the cancer. So I believe that continuous education, is able to help. And you'll not always win, but that's the best that you can do. And a lot of patience as well. That's the best that you can do. I submit. To add something else.
Oh, thank you so much. I'm very excited.
Yeah, cool. Yeah, that is where education is a weapon. Yeah, it's really like trying to educate our respective communities about this disease and the trend. And I think you guys, like this platform, you have to take such initiative like these ones. I think we do that in our hospital premises. Such initiatives are happening, but we need to go to the community.
Thank you so much for that question, and we appreciate. So there's a question in the chat box. I want to find out if there are any skincare products that can cause melanoma.
That's a
Either of
very
the
good
doctors.
question. Very good question. I'll let my doctor to start from a pathological perspective. Then maybe I'll add if there is anything. But that's a very good. Dr. Tom, do you want to take that one?
Oh, all right. Maybe if, sorry, I was a bit away. And you asked some of the products that are causing skin cancer. Yeah, of course, some of those hydroquinone, we've told you in terms of pathogenesis, especially those hydroquinone based cream. We really advocate for this one to be out of the market. Some of them, they are being investigated, and even some of the government, like where we are regulated, our market are regulated, they are no longer on our markets, especially like here, I know in Rwanda. We know this one, on top of this excessive sun exposure, they really sort of speed the melanoma from the nevus to a typical nevus and then melanoma formation. So that is one example. Maybe I know the dermatologists have a good list of them. He will add some of them. And then we've told you those tanning like reagents, I mean products. These ones also in some of the countries. By the time even WHO in 2009 realized those tanning like practices, they are part of the pathogenesis of melanoma cases, especially for those patients who have got used them over a good time. So up to you, Dr. Lyon, to go on.
Thank you, Dr. Tom. Thank you. You are absolutely right, Doc. In fact, to bring it to the Zambian context, for a long time, a lighter skin type has been associated with beauty. So all the light girls, all the colored girls, they are the ones who get the best men of society because when you're light skinned, it's so exciting. So we had a lot of influence from the Congo. They introduced a lot of this hydroquinone, BGSO, corticosteroid. A lot of our women then didn't understand the damage that it would do. But to sort of like summarize it, some of those agents that people use, they are bleaching and lightening agents. Now, how do you lighten someone? You can do it in two ways. Either you get something that bleaches the skin, or you get something that inhibits melanin. And remember, we said that melanin is very protective against cancer. So when you inhibit the melanin, you are actually reducing the protective barrier and exposing yourself to sun damage. The other thing that you need to take note is some of these products have got carcinogens in them. So more like the way you'd eat food, or at some point, I remember in Zambia there was a drink that was banned because it was reported to cause to be carcinogenic and cause cancer. So the way you find these additives in food, these artificial genetically modified foods causing those kind of issues, some of the additives in those cosmetic products are carcinogenic in their nature. Remember also that the skin, one of the functions of the skin is medication can pass through. So which means that some of the medication that we give is topical. So indeed, some of these things can go through the skin and cause this kind of damage through the carcinogenesis that they carry. And then lastly, if you take note, one of the functions of the skin is barrier function and immunologic function. Remember, we talked about the tumor suppressive cells that are basically the caretakers, the sweepers, and the protectors. So these additives in some of these cosmetics, they actually slow down or actually suppress the effectiveness of tumor suppressor cells, and this predisposes the people to cancer. There's so many we can talk about, but I think in brief we could stop there and say that should be. I hope that is helpful for you.
Thank you so much for the informative answers. There's another question. Someone wants to find out how much amount of UV light which can lead to melanoma.
Okay. Maybe I can take that, Doc. Is that okay?
Yeah, you can take that one. I know that postulates of low cumulative sun exposure density and high. Yeah, it still has a role. Like maybe you're gonna, if you have specifics of it. I've read like more than 400 nanometer sort of frequency on sunlight exposure, but you would even add more specifics on that. Thank you.
Yeah, thank you, Doc. Absolutely right. Most literature talks about 400, and however, I've found some documentation which is also confirmed that it's not so much the 400, the number. It is also a lot of patient factors that are involved in it. And that formerly, we used to say the bad one was only UVB, for example, which is at a higher frequency range. But evidence has now shown that even at a lower frequency range, there is the effects of the low range, for example, UVA. The only thing that makes it better is that the recovery of UVA vis-a-vis UVB is quite quicker. Now, I don't want to go into the complex pathophysiology, but suffice to say that anything that is UVA and B, if you look at the sunscreens now, we are now having sunscreen which has got UVA and UVB protection. Formerly, you could just get UVB alone or UVA alone. It's because science has now shown that even at 300, you can get cancer. Now, this question is also tricky in that you are forcing me to answer the question which I asked all of you, but I don't want to answer it. But suffice to say that you 300, for example, of radiation, 380 or 300 can cause cancer if somebody has got pre-genetic susceptibility, if somebody has got immune issues, if somebody has got all these other confounding factors. Number two, we also know that it's not so much the duration of the cumulative exposure as it is frequency of exposure. So evidence has also shown that if you've got somebody who's not accustomed to the sun and they go in the sun intermittently or irregularly, they are more at risk of getting melanoma than somebody who stays more in the sun. And the reason has to do with adaptive physiology, where there is adjustment and then there is cellular learning and all these molecular genetics involved. But anything from 300, like the doctor said, literature will say 400, 300 and above, you can get melanoma.
All right. Thank you very much, everyone, for those insightful questions. At this moment, I'm going to invite Dr. Michelle, who's a senior radiation therapist and vice chairperson of Cancer Webinar Series Committee.
Okay, thank you very much. I'm sorry, our speaker or Michelle is not around. Is not available. I'm gonna speak on her behalf. But before I speak anything related to this cancer webinar and thanking all participants and the speakers of today, I would like to first ask the question. My question is about, you know that we as medical students, we are bachelor students, we don't have enough connection in this field of even cancer or general cancer or this skin melanoma or dermatology. So most of the time we start these initiatives to call upon people to understand, to know those dermatological conditions, those cancer conditions, but we finally meet the constraint where because we don't have connection for some people to motivate us, to connect with us, to give us motivation in our everyday activities, we used to stop these initiatives. So I want to ask our expert of today, how do you collaborate with those young professionals or young students to help increase their motivation in this field? Thank you.
Thank you very much for the question. So what I have done is, and I'll give you the Zambian context, is that I some time ago, because of the lack of dermatologists in the country, I identified a few medical personnel in the community who were interested. So we actually forced the curriculum to include dermatology in the 5th year, because in Zambia at some point we didn't really have it as a compulsory. Dermatology was not compulsory. So at the Copper Belt level, they made it compulsory that every medical student needs to pass through and rotate in dermatology. And through that, we were able to identify a few people who were interested. I don't know if Rwanda you use clinical officers. Zambia still has clinical officers and medical licentiates, and a few of those people were actually taken keen interest in the practice. One of them actually, his apprentice, he's been my apprentice. I've been working with him. He's a clinical officer who works in the community, and he has made tremendous improvement. At this point now, he's able to diagnose conditions, which would be otherwise quite difficult, because he's been basically learning with me for quite some time. So we've done that, and then also in addition, we have now introduced dermatology as a specialty at the university, at UTH, the university under the University of Zambia, but University Teaching Hospital. There is now dermatology, and I believe that, if I'm not mistaken, it should have started or it is about to start, just to try and encourage our people from joining. And the country also sponsored a few doctors to actually go abroad and learn dermatology. I believe 2 of them should be finishing this year, if I'm not mistaken. So these are some of the things that we have done, and it has been helping because the interest has slowly been increasing with time. I hope that answers your questions.
Yeah, that's all. Okay. If there is nothing, if there's anything doctor can add, Dr. Tom, I think I may continue. Okay, thank you very much.
Erise,
Yes.
you wanna continue? Otherwise, I will say developments in the methodology training. I think we have now a 4-year like lasting the methodology residency, and then we have also surgical pathology, where those I mean biopsies for the methodology practice, especially the pathopathology, are like aligned to for definitive diagnosis. Yeah, there is still a challenge of the pathology, of course, because most of the cases we see, they are mostly inflammatory dermatosis that are sort of tricky, that needs clinical pathological correlation, and does require a clinical dermatology training. In fact, we would just leverage up these and make sure that the pathopathology is not left behind. I think that will be embedded within the curriculum. Thank you.
Okay, thank you very much. So thank you.
Sorry, before you go ahead, let me just invite our Secretary of Academics from UNZAMEDSA to say some closing remarks. Shirley Alpha.
Okay, I have talked to Shell Alpha, has also allowed me to speak on behalf of IHCRI-Rwanda and University of Zambia Medical Student Association. I think she's not
All right.
around. Okay. As closing, on behalf of IHCRI-Rwanda and University of Zambia Medical Student Association, we would like to extend our sincere gratitude to all participants who have joined us today for this important session on malignant melanoma. So your presence demonstrates a shared commitment to learning, improving health outcomes, and fighting cancer through knowledge and collaboration. Specifically, I would like to express our deepest appreciation to our distinguished speakers, Dr. Leo Chipandwe and Dr. Thomas Habanabakize, for generous sharing for their expert experience and valuable insight. Your contribution have enriched our understanding of malignant melanoma and inspired us to take a more active role in cancer prevention, early detection, and management. So in that line, I would like to ask you to allow me to briefly speak about Cancer Webinar Series. What is it? How have it come into action? What problem are we solving? The Cancer Webinar Series, it's an educational initiative organized by IHCRI-Rwanda and University of Zambia Medical Student Association with the aim to strengthen cancer awareness, building capacity among students, healthcare professionals, and creating platform where experts and learners can interact and exchange knowledge through this session. Through this session, we seek to make cancer education accessible to everyone regardless of geographical location. Why this initiative is important? Cancer, we know the burden of the cancer worldwide and in our community. Many people continue to present rate of health facilities due to limited awareness of warning signs, misconception about cancer, and inadequate access to accurate health information. At the same time, students and early career health professionals often seek opportunity to learn from experienced specialists, but may not always have access to such platform. The cancer webinar series seek to address these gaps by bringing experts directly to our audience, promoting evidence-based knowledge and encouraging prevention and early detection, and fostering culture of continuous learning. Since its launch, we have launched this cancer webinar series in April. This is our second session. This initiative has provided opportunities for participants to engage with experts from different countries and specialties. We have discussed the practical approach to cancer prevention, screening, diagnosis, treatment, and patient care. More importantly, we are building a growing community of individuals committed to reducing the burden of cancer through education, research, advocacy, and services. So today's discussion on malignant melanoma reminds us of simple and powerful lesson. Early detection saves life. We all know. Early detection saves lives. Small skin lesion that is recognized and evaluated early can make the difference between curable disease and life-threatening condition. So as we conclude, I would like to leave everyone with a call to action. Let us become ambassadors of cancer awareness in our families, school, workplace, and community. Let us encourage health lifestyle, support screening programs, seek medical attention when warning signs appear, and share the knowledge we have gained today with others. For healthcare professionals and students, let us continue investing in our learning so that we can provide better care for those who need us. Cancer control is not the responsibility of specialists alone, as you have seen in Zambia, they have 6 dermatologists. In Rwanda, they said we have 1 dermatopathologist. So since we don't have we don't have enough specialists, the cancer diagnosis, the cancer awareness is not for only specialists. So it requires collective effort from individuals, communities, healthcare workers, researchers, policymakers, and organizations like us. We are Internal Health Cancer and Research Initiative Rwanda, but we are also working with University of Zambia Medical Student Association. So together we can create a future where more cancer are prevented, detected earlier, and treated more effectively. Once again, thank you for our speakers, organizing committee, partners, and every participant who dedicated their time to webinar. We look forward to welcoming you to our future session in the Cancer Webinar Series. Have a wonderful evening. Stay safe. Continue being champion of health and cancer awareness. Thank you so much.
All right, bye.
Bye-bye all. I think if there's nothing for the moderator to add on, we may close our session today by here.
Thank you to Elise. All of you, I wish you best wishes and enjoy your weekend.
Enjoy your weekend too.